afternoon and thanks for joining us. I'm Judy Simpson. Over the past several years, we've brought you a series of programs involving the Vermont Cancer Center of UVM and Fletcher Allen. We've been fortunate to be able to draw on a wide variety of experts from the Cancer Center. The experts have helped each of us better understand the diagnosis, treatment, and research of various cancers. Well, today we're going to learn more about the Cancer Center itself. Joining me are the center's directors. I want to welcome Gary Stein and Dr. Claire Verschragen. Thanks so much for being with us.
It's a pleasure to be here, Judy.
Gary, maybe you could explain to folks who are watching what the Vermont Cancer Center is.
I'd be happy to, Judy. The Vermont Cancer Center is a series of partnerships between cancer scientists, physicians. It's a partnership between the University of Vermont College of Medicine, Fletcher Allen Healthcare, and a number of community colleagues. And it is a group of people who work really in a seamless collaboration to be able to make cancer a treatable disease.
And the center's been around for a while.
Center has been around for a long time. It's about 30 years old, and it is Vermont's only cancer center, and it is truly a destination site for cancer.
And what's the formal mission of the Cancer Center?
Well, I think probably you could define the mission of the Cancer Center as the ability to make cancer a treatable disease. That meaning to be able to maximize our capabilities in cancer prevention, early detection, treatment through clinical trials, and that is a unique advantage. It is really a unique way to be able to compete against cancer as a disease and getting beyond cancer, survivorship, recovery, and being able to grow from the cancer experience.
They mentioned the word compassionate care. What does that mean?
Compassionate care is basically centering the care around the patient, because each patient is unique, and we need to make sure that what we offer the patient will help the patient in the context of where the patient is living, what familial situation is there, the stage of the cancer. So it's really taking the whole person and bringing to that person the best treatment plan possible that will try to preserve some quality of life or the whole quality of life, while still offering cutting-edge treatments to this patient.
And what does state-of-the-art mean in the state of Vermont?
Well, state-of-the-art means that we are providing the highest resolution opportunities for diagnosis, if it's imaging, if we're looking at biomarkers. State-of-the-art means the ability to be able to maximally understand the patient and their family and to be able to work with them to get beyond the disease. And state-of-the-art means not just instrumentation, but people with maximal expertise in all of those areas.
And so the way we apply that at the hospital, we have basically what we call transdisciplinary team, which are teams of multiple experts in surgery, in oncology, in radiation oncology. We even have scientists on those teams, and they focus their expertise on one type or various types of cancers that start in the same organ, such as lung cancer, gastrointestinal cancers, genitourinary cancers. And so these experts review the case of each patient and make sure that they define the treatment plan that is the best adapted to that patient, which often includes the provision of a clinical trial, because it's through clinical trials that we really are able to improve the care of patients. And that's really the essence of being an academic cancer center.
There are so many opportunities out there that there is not one individual who has the skill sets or the experience to be able to go in to make that happen. And that, I think, is what distinguishes the Vermont Cancer Center from what one would be able to see in any one physician's office. It's the team approach. One person is never making a decision. It really is a collective decision. All of the strengths, weaknesses, and opportunities are evaluated, and it's the team approach that is truly unique and very, very important.
So at the university, we study the biology of cancers, and we're trying to understand why does that cancer likes to spread outside of the primary site, or why is this patient population more susceptible than this one? And this is done through a series of 3 programs, one that really studies the development of cancer, how does a cell become cancerous, and the second program tries to understand why, once you have a cancer, why does it spread, and what are the factors in the patient that can either fight the cancer or basically prevent the host to fight the cancer and the cancer starts spreading. And then the third program is about health and population and trying to find preventive ways to decrease the incidence of cancer or detect them early so we can intervene immediately to cure them instead of waiting until it's too late. And so these 3 programs also have scientists and physician investigators working together in more biological way, trying to figure out, this is how it works, so how then can we translate that to the patient side at the hospital? And that goes to the transdisciplinary team that then formulate the treatment plan.
And then we look at the response of the patient, and we go right back into the laboratory and ask, how can we now improve on what the patient has benefited from that particular treatment? And the expectation is patients will then be able to go ahead and benefit even that much more when you go ahead and you look at subsequent experiences.
So I think the state of the art is to be cutting edge and understanding what you're observing to make new discoveries and bring them back to the patient again.
But not every patient reacts the same way. I mean, not every patient who has skin cancer, say, will have the same reaction as the next person, or breast cancer even.
No, everyone is individual, that's for sure. But in a sense, if you take lung cancer, most people with lung cancer, there are about 20 different types of lung cancer these days because we're able to dissect them better. But if you take that subtype of lung cancer, you know that they're going to react that way to this specific treatment versus this other group that gets a different treatment. So you do have a sense on prediction and prognosis of patient depending on what you learn from their own specific disease. And even though person A and person B may react differently, in the same group there are closer reactions than in the other groups.
Right.
So that's how we really try to focus and advance.
But you've actually asked a very, very critical question. And how can you go ahead and understand that particular patient and that particular disease that that patient is encountering? Well, no 2 patients are alike and no 2 tumors are alike. And that is now appreciated. At one point in time, physicians and scientists were looking for a cure for a particular tumor and a particular indication of a particular tumor. But now it's recognized that every tumor is different and every patient is different, and we're looking for signatures. We're looking for cohorts of indicators for a particular tumor. We're also following the progression of each patient's disease so that the treatment is going to be modified as the disease is going to progress. And there's a couple of terms that are used for that. One is personalized medicine. The other is precision medicine. But making cancer a treatable disease means understanding the total picture and being able to treat as the picture is going to go ahead and improve. Or if there's a setback, you want to be able to go ahead and jump 2 steps forward. That's approaching a reality.
Yeah, and so one of the things we do is to take a piece of the tumor of the patient at the time of the diagnosis when we make the biopsy, and then we submit it for analysis of the tumor. So we're trying to understand what's the biology inside that patient tumor, and that gives us a signature or a panel of possibility on how we should treat that patient. So we do that very well for breast. We're starting to do that much better for lung cancer. There are still, other cancers that are more difficult to subclassify, but I think that we are learning that cancer is not just one disease. And if you go to big cancer like breast cancer, colon cancer, lung cancer, they're not one disease, there are many different diseases. And that's what we need to sort out to give the best treatment possible to the patient.
Let's share with our viewers how the Cancer Center is funded.
Well, the Cancer Center is funded through several sources. One is scientists and physicians apply for grant funding from the National Cancer Institute. It's a highly competitive process, and this cancer center has a very significant amount of funding from the National Cancer Institute. And that really is an endorsement from the National Cancer Institute and from colleagues throughout the country. Philanthropy is more important than ever before, and it is the generosity of our patients, it is the generosity of our community, and this is something that we really are in together, and that's a good example of where it works two ways. There's an investment that's made in the Vermont Cancer Center, and the investment is paying off by providing Vermonters with cancer detection, cancer treatment, where it is sophisticated, it is effective to the point there is no reason to go beyond the Vermont Cancer Center.
Do you think the community in whole recognizes this resource right here in the community?
We hope so, and part of our job is to be able to get that message out.
Mm-hmm. Well, I can tell you that in the last 3 years, the number of visits we've seen in the Cancer Center have increased by 14% every year.
Really?
Yeah.
Wow. What types of research are currently happening?
Well, there is really the clinical research, the one we offer the patients. Now, of course, they don't have, it's optional,
right.
But usually if it's a cancer that you don't have a curative treatment, it's probably the best way to get a cutting-edge treatment and a hope that we can make a difference. And then there is research that happens at the bench in Gary's lab and other labs. And then there is the research in between where we're trying to link what's happening on the bench and what we can offer the patient. And that's what we call the translational research. And we are really trying to have partnership between physicians and scientists to come up with this research that will eventually affect the patient life and prognosis.
It sounds too, though, that the patient is a partner in this as well.
The patient is very, very definitely a partner, and the patient is going to benefit from the information that we learned from previous patients and their tumors, and that benefit is going to go ahead and be realized, I mean, during the treatment process and as they recover, but they in turn are contributing towards what is going to be learned further about the disease. I think what is really key is there is no such thing as I or me. It's always we or us. And you could hear it in the clinic, you could hear it in the laboratories, and that to me is a very, very unique environment and one which is highly productive.
And no, as a physician, I always find that the patient that teams with me and challenges me a little bit, asking me the tough questions, no, why do you do that, or why don't you do that, gets me to think more, and so the outcome is a better rounded solution for that patient. So I would, I like patients that ask questions and challenge a little bit the doctor.
And how does the center interact with our region? What role do regional partners play?
Regional partners are engaged in many, many ways. We work with the school systems to be able to go ahead and to explain biology and to be able to explain cancer. You can explain lifestyle to these students as well. That's important in terms of cancer prevention. We work with regional colleges. We work with regional cancer centers. A concrete example is we have relationships, formal relationships with the Norris Cotton Cancer Center at Dartmouth, with the University of Massachusetts Cancer Center. We're working with Maine Medical Center. Why, just yesterday, Claire and I were at a meeting with all three cancer centers, and they were looking at a problem called genomic instability. How are genes vulnerable to changes that are going to be related to cancer? And that's a very direct example of a partnership where you take the physician investigators, the scientists, you meet once a year, you meet many times during the year, but here's a formal meeting where everybody gets together and asks, what have we learned? What can we do that's going to be able to move things forward? And it is very key. And we could see over the past few years the difference that that's made. It's significant.
And then the other relationship we have is with the Fletcher partners, where physicians from CVPH in Plattsburgh or CVMC in Barre, we're really starting to work way more together, and we're trying to figure out how to basically come up with a standard of care that is the same wherever you go in the region, so that the more complex case would still come to Fletcher Allen because there is more physicians and more expertise in general. And at the local regional hospital where you have general oncologists, you would be able to give the care of the patient closer to home, so they wouldn't have to travel out of state or out of town. And so we're really trying to build those relationships right now.
And it is competitive, but we're competing against the disease.
Exactly.
That's
if you want to learn more about
teaming together.
the Vermont Cancer
Precisely.
Center, I think we have an address and also a website and a phone number for people if they need more information on the Vermont Cancer Center. I want to thank you so much for joining me today.
Thank you.
That's our program for today. I'm Judy Simpson. We'll see you again next time on Across the Fence.